Morning. Good morning. Yes, good morning. Very good. Good morning, good morning, good morning. Hello, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Check, check, check. Check 1, 2. Good morning. 1, 2. Good morning. Hello. Hello. Test. Test. Huh? Check. Hello. Hello. 3 தானே 3 or 2? 2, 2. 2, 2. 2, 2. Check. Huh? Hey. Check 1, 2. You speak to him only, sir. Now you don't speak to me. I already told him, but they can't understand. You speak to him only. Check. Hello. Test. Test, 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 test. Check, check, check. Hello. Okay. Good morning. कौन? Malesh. 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 Malesh.
and the psychosocial effects during chemotherapy, our institute experience. AYA population constitutes 40% of world population. In that, 6% of patients having cancer. The spectrum of cancer in AYA population is unique. The incidence of cancer in female group is breast, followed by cervix, leukemia, ovary, thyroid. In male group, testis, leukemia, lymphoma, colorectum, and CNS tumors. Many research have reported unique medical and psychosocial concern in fertility preservation, long-term side effects, parenting, education, employment attainment, retention, and financial issues. We assessed psychosocial effects in 100 patients with these tools, NCC and distress thermometer. It assesses psychosocial distress in AYA patients, cancer behavior inventory survey to assess self-efficacy for coping with cancer, supportive care needs survey, and experience in close relationship scale, mainly for young adult population. The results conveyed in psychosocial distress, mainly in adolescent population, the main concerns were missing out school, college days. In young population, the main concerns were childcare and financial problems. In supportive care needs survey, the adolescent concern were not able to do their own things, local symptoms and anxiety. In young adult population, the main concern were relationship status. They worry about mainly the cancer, disease progression and the treatment and local symptoms. In cancer behavior inventory survey, the adolescent main problem were sharing feelings, isolation, alienation. In young adults, the areas of concern were managing symptoms, expressing negative feelings about the cancer, maintaining their day-to-day activities and work, and coping with physical changes. The site-specific questionnaires, the main problem were many of the patients worried about local symptoms, change in their physical appearance, trouble in going out in public, worry about in young population, the main concern is about sexual activity. So prevalence of AYA cancer is on the rise over the recent years. AYA patients presenting in stage 4 are also increased gradually, and poor treatment outcomes may be attributed to this advanced stage of presentation of this particular population. Low treatment compliance found in this age group can be improved with patient education, disclosing age appropriate information to patient, and the family and peer support. This AYA population should be treated as separate entity, considering the unique physical and psychosocial problem they face. Separate clinical trials should be done in this population, which can account for the problem of this distinct tumor biology. Special consideration should be given to psychosocial distress by means of professional counseling, age-specific support groups. Physical symptoms due to cancer which may result in distress may be duly treated. Finally, the youth is the hope of our future. He is one of our AYA population. He successfully conquered cancer. That is extragonadal germ cell tumor. Now he came out of cancer. He is a role model for many AYA population. Thank you.
I think we'll ask a few.
What are the specific points you have identified and how to address those points?
Mainly in adolescent population, they're missing out school, ma'am, and they're having poor knowledge about the disease status and the treatment outcome. So they are skipping chemo schedules. We are treating mainly low socioeconomic status. So their parents also not able to understand the disease status, treatment outcomes. So and financial issues also there. So many patients skipping treatment. So we are mainly counseling these patients for treatment. We had an osteosarcoma patient, 18 years male. He skipped the treatment after 2 cycles due to low socioeconomic status and the poor knowledge about disease. So I take this study because of that person only. So I'm mainly counseling all AYA population, explaining the treatment outcomes. Mainly I'm treating the patient with the positive counseling.
One very important question is, what do you think is the impact? Why did you ask this question? So every research starts with a question. Why did you ask that question? What impact? Because clearly he's not the category of patient that
Yes, sir.
Interviewing.
Sir, mainly many patients defaulting, sir. So with that question only I started this study, sir.
But
so
how will it impact? What information have you come up with,
yes, sir,
which will set the seeds for the next research, which will impact outcome in some ways?
Mainly proper counseling, sir. Proper counseling of each cycle, so patient will understand the disease status, sir.
One suggestion,
Yes.
just also, is if you look at next steps, look at social support groups, if you can formulate that.
Yes, sir.
In the era of AI and technology, right?
Yes, sir. Sir, in children we are having a support group in our hospital, but AY population we have to formulate, sir.
Thank you.
Yes, sir.
That was fantastic. Thank you. I think we'll have to keep it short though.
Doctor, I'm Dr. Naveen Machado, family physician with 45 years in medicine. I
Yes,
have
sir.
had patients recently, for example, a small child, 4 years with leukemia.
Yes.
And I think the difficulty that we have in India is we don't have tumor boards across like they have in the West.
Yes.
And therefore, the entire schedule of what the financial burden is there is not explained to the patient before treatment is started.
Yes.
That's a good comment. Thank you. Can I have Mr. Sajan
Thank you.
do the next one? Thank you. Sajan.
Good morning all. My name is Rajan. I'm a psycho-oncologist at Fortis Hospital, Mulund. Today I'm presenting a paper on Beyond the Scrubs, Stress, Mental Health and Coping in Oncology Practitioners. So introduction, as we know, oncology healthcare professionals are often find themselves at higher risk of burnout and in continuous stressors in their work. Stress in oncology is particularly concerned with healthcare professionals with increased absenteeism, anxiety, depression, sleep disturbances in junior residencies that has been already found. And they also play a crucial role in supporting patients and their family through difficult times, delivering bad news and making complex ethical decisions. However, there are very limited studies that are present understanding the mental health concerns of the oncology healthcare providers, especially doctors, staff nurses, and junior residents, and rarely a few in oncology. So my aim of the study was to assess the stress, quality of life, mental health issues, and coping adopted among oncology healthcare professionals. So these were the objectives that were framed to understand the level of stress in cancer ward, to explore the prevalence of stress, anxiety, and depression among the oncology healthcare professionals, to assess their quality of life, to identify their coping styles, to develop an intervention module that is phase 2. This is an ongoing study that has been conducted. Where is the next slide? Sorry. Yeah, next slide, please. Yeah. Okay. This is the methodology that I have done. It's a single-center study conducted at Fortis Hospital, Mulund from the December 2023 to January 2024. A purposive sampling technique was employed in the study. A sample of 32 healthcare professionals, including consultants, junior residents, staff nurses of the oncology department in our hospital were taken for the study with consent. The study used 69-item stress in cancer ward developed by Aldrich and Fitzgerald in 1990. This is the only one questionnaire that can be found that supports the oncology. The rest of the other studies that were done in oncology setting were perceived stress skills that was not in perfect correlation. So this is a study that was adopted for this, and WHO QOL and 21-item DAS and 28-item coping strategies brief cope. The data was collected through the electronic form with consent. The data was further analyzed and interpreted with SPSS version 20. As you can see, there were 90% of female participants and 9% of male participants. Of them, which 65% were staff nurses and 21% were doctors and consultants, which included the preliminary analysis of 32 samples where 1:9, where 11 doctors, including consultants, junior residents for medical oncology, radiation oncology, pediatric oncology, non-oncology doctors, and 21 nurses took part in the study. So these were the results findings. Among those, 49% of the participants showed higher than average in terms of stress in cancer ward, and 4 out of 32 staffs have reported severe stress. Doctors have reported higher stress levels than nurses, as you can see in the table, and 25% of the staff on rotational or on call have reported higher stress level than the morning shift or the night shift. And along with this, the DAS scale has provided with the report that moderate levels of depression and anxiety has been reported almost 25 and 50%, with anxiety on the higher level, 50%. Stress in cancer ward was positively correlated with depression and anxiety and negatively correlated with quality of life, which in case when stress increases, quality of life decreases. Now, coming to the quality of life, as you can see here, there are 4 major domains of quality of life in which the psychological component is very less. It's very evident. And the mean score indicates the reduced quality of life in psychological domain with a mean of 52. In brief scope, there are 14 subdomains, but of which collectively doctors and nurses prefer the coping styles of active coping, religion, and acceptance. So summarizing, it is an evidence that we have got with the 32. It's an ongoing study that prevailing clinical mental health conditions such as depression, anxiety, and stress is prevalence, and minimal efforts have been made to address it. And the phase 2 study would be identifying the major distress in a qualitative study and developing an intervention module such as supportive group and individual counseling for the doctors, junior nurses, residents. I want to take a time and thank all my Fortis team and my partner Maria. Thank you.
Thank you very much. We'll be very quick. One question from me is, any interventions you think that can help in solving very evident crisis?
Yes, so that is a phase 2 study. That's what I'm about to continue, where I'm planning to have a support group for the doctors separately, for the consultants separately, once in a month. And it's a pre-post test, an experimental test where I can evidently have a statistic data, how it is effective for the doctors, for the nurses separately, and the junior residents.
Are you planning to extrapolate this data and identify, have a different groups? As to you have identified only the oncology caregivers.
Yes.
The non-oncology caregivers are also under stress.
Yes.
So we will have to distinguish the stress level between the oncologist
I have taken non-oncology practitioners as well, but the only limitation of the study was the sample size was low.
So
yes. So we need to, when the sample size is increased, we will be having a much cumulative data.
Yeah, probably we
yes.
need to have a comparable arms to
Yes.
quote that in oncology it is quite higher than the
Yes.
other care groups.
Yes.
Thank you very much. Can I have Mrs. Tamanna D? And I'm sorry, but we'll have to cut it to 3 minutes, 3.5 minutes max, so we can ask question and close at 5. Also, this is being live streamed. There will be some QR codes outside. And the first prize is 1.5 lakh rupees, and then 70,000. And there are e-posters also, which will be going at 2 p.m. Yeah.
Good morning, I'm Tanmaya and I'm a genetic counseling trainee at Kamaneni Hospitals. So today I want to talk about the importance of genetic counseling and cascade testing in cancer surveillance and prevention. So cascade testing, as we all know, is when a patient who is affected with cancer has a particular genetic variant identified in them. And what we have, it's imperative that we test the family members as well so that we can estimate the levels of risk, manage the risks, and also provide treatment implications as well for them. So to introduce my topic, I want to talk about what genetic counseling is. It's basically a communication process that helps individuals, couples, families, and to understand and adapt to basic medical, psychological, reproductive, and genetic contributions to the disease. So how GC plays in hereditary cancer syndromes is because when they have an inherited mutation, they have an increased risk of developing certain cancers at a relatively young age. And 10 to 15% of cancers have a hereditary basis, and patients need to undergo germline testing for diagnosis in general. Now, once this particular variant is identified, we test all family members to see if that particular cancer is inherited or not. And this is imperative because you can give appropriate treatment, early diagnosis, and prevention and management of different cancers. So the methods were 16 patients who had breast, ovarian, colon, and pancreatic and thyroid cancers were counseled for carrying out either particular gene variants like BRCA1 or BRCA2 gene testing, or a whole panel which included 28 gene germline testing based on their medical and family history, and subsequent post-test counseling was done based on the report obtained. So we saw pathogenic, likely pathogenic, and VUS variants in about 18 out of the 61 patients, and out of these 18 patients, 13 of them, along with their families, came forward for cascade testing. So, excluding the affected patients, a total of 37 at-risk family members, based on their pedigree, were tested. 19 individuals in 6 families had the same variant as the patient, and 18 individuals did not have the variant. We found variants like TP53 associated with Leaf-Romany syndrome, primarily BRCA1 and BRCA2 variants, multiple endocrine neoplasia, which is associated with the Rett gene, and Lynch syndrome. So this is a pedigree. It's a case of a patient who is affected with triple negative breast cancer. Both her children were tested, a son and a daughter, and the daughter was the carrier for the same variant as the mother, which is a BRCA1 likely pathogenic variant, and the son was not. So there are two different levels of counseling, almost done. There are two different levels of counseling involved, one where we reassure the family member, and where the other when we can, give appropriate surveillance plans for the other daughter who was found to have the same variant. To summarize, both pre and post-test genetic counseling is important for cancer patients. The 18 individuals who did not carry the variant were reassured that their risk is equivalent to general population risk, and the 19th who were identified as carriers were given surveillance, prophylactic and surgical intervention plans, regular colonoscopies, mammograms, blood work, etc. And genetic counseling is crucial in a low-resource country like India for reducing financial and emotional burdens of families with HCS. And we all know that cancer is a devastating disease, and with this, we're not helping just one patient, but their family as well. Thank you.
Excellent. This is very relevant. Resource limitation is a problem. Why don't we do away with personal counseling and just replace that with provocative question? But if you do not need person-to-person counselor to genetic counselor, let's say you make
of 147 patients. The primary patients were 229, and the patients taken were recurrent metastatic squamous cell carcinoma in the head and neck patients. And out of them, 147 patients were of oral cancers, and they were divided into two arms. One arm was having the patients who received cetuximab along with the chemotherapy. The number were 88. And the patient in the other arm, which receives only the chemotherapy, was 59 patients. And the endpoint which we have seen in the study is overall survival and the safety of the patients. The anatomical sites of the oral cavity includes lip, alveolar ridge, hard palate, anterior two-thirds of the tongue, floor of the mouth, retromoral trigon, maxilla, parotid, and buccal mucosa. So the results in the majorly patients which were included in the studies were the male patients, and the ECOG status was better in both the arms. The ECOG status 1 in the patients who received chemotherapy along with the cetuximab was 72, that is 48.97%, whereas in the arm which received only the chemotherapy was 38 patients, which is 25.85%. And it was 16 in case of ECOG-2 in the patients who receive chemotherapy along with the cetuximab. The patients who receive chemo and the cetuximab, the local recurrence was in 44.2 to 21% patients, and the metastatic setting was 15.64%. Whereas the patients who receive only the chemotherapy, the local recurrence rate was 23.8%, whereas metastatic setting was 16.32%. And the disease status was the stage 2 disease patients were only 4% in the first arm, and stage 3 patients were 30.61%, and stage 4 patients were 23%. Whereas in the arm which contains only the chemotherapy is 2% in stage 2, 18% in stage 3, and 18.36% in stage 4. The overall survival in the partial response was seen. The arm which contains cetuximab along with the chemotherapy was 73.86%, whereas 45.76% the patients who receive only the chemotherapy. And the stabilized disease was seen in more in the chemotherapy along with the cetuximab patients, and the progressive disease was more in the other arm, which the patients who receive only the chemotherapy, which was 25%. So the overall the response progressive disease was seen more in the chemotherapy arm patients. So this is a median OS, which is the cetuximab administration of the chemotherapy. Cetuximab administration of the chemotherapy regimen beyond the progressive results in almost doubling of the OS, which is 12.23 months versus 5.8. And the adverse effect is only the skin reaction, which is majorly seen in the cetuximab as compared to that of that one. So among oral cancer patients, adding cetuximab to the chemotherapy doubles the OS, and the cetuximab was well tolerated. Only the skin reaction is the major side effects. Thank you.
Thank you very much, Neha. Quick question, this is already known. What's new about this?
So this is a majorly the largest study which was performed in the patients who in the oral cavity, head and neck cancers. So
okay.
What was the primary driver why people were given cetuximab plus chemo versus chemo?
So
that's what was the driver? You didn't mention why some people got cetuximab plus chemo and some people just got chemo.
So the majorly the economical variant was there. So the patient who are able to.
So there was no other confounding factor other than economic status.
So majorly was economic, and some patients, the centers were not the availability of the drug, and the major concern was the economics only.
Thank you, Neha. Can we have Neha Yadav again? You have two presentations? No, okay, thank you. Can we have Akrobek Yush P. Bevkov? That was a difficult, no, not there, okay. Can we have Hemant as Galanch? Thank you.
Good morning. Myself, Dr. Hemant. Warm greetings from AIMS Bhubaneswar. I am presenting a paper on prognostic implication of worst pattern of invasion in oral squamous carcinoma, analysis of prospective database from Eastern India. So as we all know, T stage, N stage and M stage along with LVA and PNI are already established prognostic factors for oral squamous cell carcinoma. Here we have made an attempt to prognosticate significance of WPOI in terms of oncological outcomes like recurrence and survival. So it was a prospectively maintained database analysis of all the patients who were operated in February 19 and August 23. And only the patients who underwent curative resections were included, and patients in whom WPA was not assigned is graded from 1 to 5, 5 being the worst. And for the purpose of the study, we have grouped the WPA into 3 groups. Group A is WPI 1 and 2, Group B is 3, and Group C is 4 and 5. So Group A had 13 patients, Group B has 39 patients, and Group C had maximum 68 patients. So we have done a univariate analysis among the 3 subgroups with gender. It was a 4:1 ratio of male to female. There was no statistical significant difference between the 3 groups. The addiction patterns were also similar in all the groups. The most common subsite in the oral cavity in our population was alveolobuccal, approximately 50%. There was no intergroup variation, and T4, the most common stage also was T4, being 44% in the group C, 33 in B, and group A was 23. The nodal positivity was more in the group C, that is 45%, and group B had 30%. Between the group intervariable, the p-value is not statistically significant. The LVA and PNI were more commonly seen in group C, amounting to 42 and 58 as compared to the group B. The poorly differentiated category was mostly seen in group C. So however, the WPI did not determine the adjuvant treatment plan. So only based on the described prognostic factors, we have given adjuvant therapy. Radiation was received in 23 in group A, 46 in group B, and 44 in group C. There was no intergroup variability with respect to CTRT as well. As is evident, the recurrence and mortality were more compared to group 1 and group 2. That is 12 and 17 and 23% in group C. Our p-value was not statistically significant. So after a median follow-up of 16 months for OS and 13 months for DFS, the OS was 92%, 69 and 65% in group A, B, C, and the DFS was 90, 64 and 56. The same has been depicted in the Kaplan-Meier. All the 3 graphs are separating. So to conclude, worst pattern is an outcome predictor for both recurrence and mortality, but no significant adverse prognostic factor for oncological outcomes. However, the limitation of the study is larger sample size has to be there to assign the association between worst pattern and the oncological outcomes. Thank you.
Thank you.
What is the implications of your work, and where do you need to or want to take it from here?
Sir, wherever the 2 risk factors are there, these are now already people are following for adjuvant therapy of radiation. So in patients who have, suppose a tongue primary with a worst pattern of vision of more, they can consider for radiation. But tongue in our subgroup is only 30%. So maybe with more sample size, we can add on to number of risk factors. When LV and PNA is negative, still whether we have to go ahead with radiation plan or not.
When worst pattern of invasion is around 4 or 5, usually we see LVI and PNI positives also. Do you observe that, and how can you exclude it as a confounding factor in the prognosis?
So in our group also, as we can see, LVI was C was in the group C, it was LVI was 17% in comparison with group B, which was 5%, and 42% in group C and 23.
Yeah, so it is higher when WPOI is also higher. So how can you exclude this confounding
only
bias?
More sample size can answer this hypothesis.
Yeah, I think the key question is, can we do less to predict the same thing though? Because again, head and neck is such a large volume disease here. So if we can do less, then maybe we can predict more. So of all these factors, was there 1 or 2 factors which you think is likely to be most important in your next bigger volume study? Would you power your study to look at those factors separately?
So PNI.
PNI. In fact, we find that too. Thank you very much.
Thank you, sir.
I think this was very interesting. Can I have Pramukh N to do the next one? Thank you.
Can I start, sir? Hi, good morning. Today I would like to be presenting on the topic of the role of Rehab-centric MDT, which is a multidisciplinary team, in its role with respect to head and neck cancers. So the complexity of the head and neck cancers as we approach, so we are always hit with the challenges of difficulty of swallowing, difficulty of speech, and difficulty to continue the tasks on a day-to-day basis for the patient, which will turn out to be difficult post-surgery and which is on a more worst state, which when they take a concurrent RT and concurrent CT as well. So my article focuses on the role of how prehabilitation, which would be called as a concept, wherein which you involve our fellow colleague and other faculties which would be there. So to basically plan how to execute a rehab-centric approach for a patient. The rehabilitation actually plays a crucial role in comprehensive management. As a multidisciplinary approach, this contributes significantly for improving the quality of life of patients and their functional outcomes. So the group which would be formed would be led by a surgeon and a member of the speech and language pathologist, a physical therapist, nutrition and dietitians, psychologists and counselors. So each having its own key responsibilities. So one, the members of this particular group, sir, I just wanted to have a presenter view. The speaker notes are not there. Speaker notes which is there. Thank you so much. So the main responsibility for this would come as a part of collaborative decision making, where specific cases, probably advanced head and neck cancers, can be discussed as a part of the team, where decision can be made and a patient-centered and what the theme of this conference, which is there, practicing precision oncology, which is there, to plan each component of it. The roles and responsibilities would be basically the medical treatments planned by the surgeon and the speech language pathologist to plan for how would be the voice processes as well, which is there. Benefits, this would have a very holistic approach, a very patient-centered care and improved outcomes as well. So if we go through the current literature, there is actually studies which shows that swallowing post MDT, which would be there, rehabilitation is role with minimizing long-term functional impairments and is also ables with faster or reduced hospital stays. The current challenges, utilizing the MDT, a rural-centric approach which would be there and which forms as a difficulty for penetration. And if we can actually have a tele-MDT session which would be there, this basically helps us to plan in an internet-centric world currently. So to conclude, rehabilitation-centric approach, teams are vital in addressing complex challenges posed in head and neck cancers. As an evident current literature, MDT gives a significant improvement in the quality of life. Thank you.
Thank you very much. This is extremely relevant. But how will we scale it up? Because the skill across the country is negligible on this.
Sir, we actually have tumor boards across the country which are active, and so actually looking at this forward, we actually have to involve like take a lead for something like a regional cancer center or something which can have a multidisciplinary team as a part of the treatment planning thing, where tumor boards can actually be very specific to plan cases which is there. Sir?
No, I think we won't be able to take questions. We're running short.
Do you think artificial intelligence and robotic surgery will help you with the problems of swallowing and speech?
Sir, artificial intelligence, definitely yes, if we put the subsets. But robotic surgery currently with respect to oral cancers, it's for mostly oropharyngeal cancers will give a much specific outcomes, because if we have to do other neck dissections which would be there, role of robotics is mostly limited to a scarless surgery which is there.
I'll discuss this with you shortly. Thank you very much.
Thank you so much, sir.
Can I have Mr. Sudarshan Gupta, the last participant? Very interesting question. Sudarshan Gupta? Okay, he's not there. That's perfect. That saves us some time then. Can I just ask my judges to give a final comments on everything they've heard this morning?
Just want to congratulate all the presenters, and nice to see the work coming along. Obviously, we have a long way to go, and I see India is just scratching the surface. I think multidisciplinary management is going to be the key as we get more and more therapies into the clinic, which makes sometimes decision making more individualized and relevant for Indian experience.
Congratulate all the presenters for your wonderful ideas, and you are bringing in new insight to the practice of oncology, not only the therapeutic part of it, but also the overall holistic part of the oncology. So we would like and wish to see these researchers with a greater group and broader designs, so that the results can be applied over a large group. Thank you.
Thank you very much. I think my key comment is that these are great thoughts, some very good studies. I would really be very excited if in fact you join at least a nearby hospital. Try and increase the numbers by joining hands, collaborating with colleagues and friends. I mean, and suddenly you'll see the power of number come up. That's one thing which is not short in India.
I think we should use virtual platforms to enhance all this, because otherwise the reach is very limited.
So with that, thank you for the morning session. We'll be starting very soon at 9 o'clock with the plenary. Thank you.
Good morning, everyone. Today is going to be a landmark day for Fortis, with the Fortis Cancer Summit first happening in Bangalore. With this, I would like to invite Dr. Neeti Raizada, the organizing chairperson for this conference, to deliver the welcome note for the Fortis Cancer Summit 2024. I would like to invite chairpersons, Dr. Vijay Kumar sir from Mangalore, Dr. Harit Chaturvedi sir from Delhi, Dr. Rana Patir sir from Gurgaon to join on the dais.
A very good morning to one and all. My dear oncology esteemed colleagues, I welcome you all on the first day of the inaugural event of our very first Fortis Cancer Summit at Bangalore. It's an honor that we have this gathering today with such distinguished professionals dedicated to advancing cancer care. Over the next 2 days, let's collaborate, share our experiences, and work towards innovative solutions that will undoubtedly shape the future of oncology through precision. Thanks so much for being part of this transformative journey. Welcome once again. A very good morning.
Thank you for that, Neeti, and it is truly an honor to actually see everyone here. Can I start with the first session, which is pathbreaking work of 23. We'll be focusing on adjuvant, somewhat neoadjuvant, early breast cancer. I'm really honored to invite Shaina Dawood, a close friend, one of, to my mind, the best medical oncologists in breast in the world. Shaina, please take over as the moderator. Can I invite the panel, please? Dr. Sapna Nangia. Yes, ma'am is here. Dr. Geeta K. Dr. Anupam Mane. Thank you, ma'am. Dr. Rajkumar Ramaswamy. Thank you, sir. And Dr. Harish from Bangalore.
Presentation mode? On presentation. It's on presentation mode? No problem. So good morning, everyone, and thank you for the invitation. Always lovely to come back to India and participate in these platforms. So today, Nitesh actually asked me to discuss path-breaking data in 2023. These are my disclosures. Before we start, I wanted to set some rules. So the rules for today for all the panelists and even for the people in the audience is that all your patients are rich. You have access to all the medications. Pharma gives you free medications after this symposium. And cost is not an issue, and you cannot enroll your patients in a clinical trial. So it's the ideal world that you're going to be treating your patients in. So my first question, actually to Nitesh, and I know he has a mic, in 2023, what did you find exactly that was path-breaking for the treatment of early-stage breast cancer? Because honestly, I didn't find anything path-breaking.
No, I think the role of CDK inhibitors in adjuvant setting is genuinely path-breaking, because that is an area where we are seeing curability already, and to raise the bar there for the most common cancer in India and the world in women is actually pathbreaking.
Okay. So
yeah.
And this session is
That
only for early breast. So maybe we can ask the panelists, what did you find path-breaking that really altered what you did in the clinic on Monday?
So I'm a surgeon, so for me, I don't think there has been anything honestly path-breaking as far as surgery is concerned. All that I know is that there is a lot of noise in medical oncology, and every day there is a new drug. And I keep wondering, even if I were to learn one name, so that is what I promised to myself, at least I must get one name right. So I still may be getting it wrong. Capicertib.
Capivasertib. It's just been FDA approved.
Capivasertib. That is the only name that I got right, so that's an achievement.
Skipping the surgery may be the path-breaking.
Yes, please. Who else? What did you find path-breaking in 2023?
Nothing, no single study or trial as such, but there has been a lot of noise about omitting axillary surgery and all, a lot of abstracts and studies have come out. So even though it is not always applicable to all our patients, but I would definitely keep it in mind while operating axilla.
Okay. I think you had your hand up.
De-escalations should be the mantra.
Okay.
De-escalation not only in radiation, de-escalation in axillary surgery, de-escalation from a toxic chemo to a non-toxic one, more of a precise, that is de-escalations everywhere. De-escalation should be the mantra.
How many med-oncs do we have in the panelists? All right. Okay, so
de-escalation in surgery and radiation, and when it comes to the
medical.
De-escalation in medical oncology also, moving from an anthracycline toxic chemo to a non-anthracycline based chemo, moving to a more targeted agents. De-escalation is everywhere.
I'm sorry to disappoint you. I will not be discussing anthracyclines. I've done it to death. I think we need to move beyond anthracyclines in medical oncology. So let's get to the questions.
May I? You forgot the radiation oncologist.
And I'm coming to you actually. I have a very nice case for you.
Right. So I would think that the focus in radiation oncology has been, again, on de-escalation. And there have been at least 3 studies that have been published in the last 1 year, which have, they're all single-arm studies, but which have looked at whether we may de-escalate. It's early days yet, very good, what should I say, very good prognosis tumors in older women. However, the data is only limited to 5 years, so I think there's time yet before we are able to. And if I may?
Sure.
So personally for me, I think what has been most critical is being able to present our experience in proton therapy for breast cancer and, create an awareness about how the cardiac risk in South Asian women is different from the rest of the world, because we as South Asians have a higher risk of having a cardiac problem, and therefore drawing attention to how reducing cardiac dose can reduce the toxicity of treatment.
Okay, so let's get into the questions in 2023. I think these were the questions that were not path-breaking, but allowed us to expand how we treat our patients in the clinic. So the first question, like Nitesh said, who should receive adjuvant CDK4/6? We know they should receive it, but who should receive it? We saw the 5-year update for Monarch-E. Everyone knows Monarch-E, adjuvant abemaciclib in those high-risk group of patients that were enrolled in Monarch-E, ER/PR positive, HER2
surgeons in the panel have an opinion on this too.
Really? What do the surgeons think? Up to how many months? Harith, you're a surgeon. Up to how many months? 12 months? Okay, so let's go to the next question. Monarch E had a Would you consider adjuvant abemaciclib in this cohort? Anyone can take the question. Ankur, what do you think? What are your thoughts here?
In the latest OS data, when it was not still showing, but the trend was for those patients who are having high Ki67. Like more
Yeah,
than
but they were not reported separately, the 1 to 3 lymph nodes and only Ki67. So it's like a really separate
So
cohort.
it can be one of the criteria where we can add abema to it.
Okay. Nitesh, you have anything to add?
I actually would not yet.
Okay.
I think it is important for some level of either survival data to come out,
Okay.
or at least you start seeing the separation of curve. The reason we are comfortable with the prior question is both because we have data, but we were already seeing the curve separate last year and the year before. So
For the survival data to come through in an ER/PR positive, HER2 negative is going to take
Would
a long
take
time.
decades.
Yes. So the other thing is your ribociclib is in contention very shortly.
And I'm coming to that. I'm coming to
all
ribo.
Your criteria actually fall flat because
Yeah.
they're using your 1 to 3 lymph nodes. So everything is high risk when you look at the ribociclib criteria.
Yeah.
Much less stringent than what abemaciclib is.
Okay. So let's look at the fact that we now have Natalie. Natalie came out this year. And Natalie was another adjuvant CDK4/6 inhibitor trial that took ribociclib with endocrine therapy, but here you were giving 3 years of adjuvant ribociclib. And you can see from the table on your screen that in fact a broader cohort of patients were included, including node-negative patients, who had oncotype scoring that was high risk. When you look at the IDFS by anatomical stage, you can see that both stage 2 as well as stage 3 patients benefited. It's really difficult to see these curves, but you can see that they are separating and that there is a statistically significant benefit to giving ribociclib. In those patients node negative as well as node positive, again, you can see that there is a benefit, but when you look at the node negative, the confidence interval is crossing 1. So again, when they're splitting it into these different groups, you can't really say that one group is benefiting more than the other. So my first question to the panelists, in a patient with more than 4 lymph nodes positive, so fits Monarch E, fits Natalie, do you believe that abemaciclib and ribociclib in this setting are interchangeable? You believe that they're interchangeable? Anyone else? Ankur, do you believe that they're interchangeable? Okay. Nitesh, do you believe that they're interchangeable?
I don't think anything is interchangeable actually.
So if you had a patient, and we're sharing a patient right now, 10 lymph nodes positive, she's sitting in your clinic,
So
cost is not an issue. What are you going to give her, abemaciclib or ribociclib?
So I think because I have both choices officially, I'm more tempted at abemaciclib because I can see those curves are really separating out. And while that's a prediction, we don't know what PFS2 will do. But if I have a choice, I would use abemaciclib at the moment.
So I did a roundtable discussion recently with KOLs from Europe and US asking the same question. I wish I'd put the voting answers over here. 100% said that in this type of setting, they would only use abemaciclib because the data is strongest there. Now, Natalie does give you that option, but it doesn't have as long a follow-up, and the benefit hasn't been shown in terms of those wide separations in the Kaplan-Meier curves. It's not wrong to use it, but the data is strongest in Monarch E. So let me make it more complicated. You have a 65-year-old lady sitting in your clinic, PT1, N1, HR positive, HER2 negative, Ki67 is 5%. She has a grade 1 disease and an oncotype of 11. She's not going to get chemotherapy, so even the surgeons are going to treat her. What are you going to give this lady? Endocrine therapy alone, or are you going to give her endocrine therapy plus a CDK4/6 inhibitor? Anyone can take this question. Okay, you will not send this patient to a medical oncologist. Okay.
You know,
So-
a surgeon can be a medical person, but a medical person cannot be a surgeon.
So what about our med-onc on the panelists? Would you, because she fits Natalie criteria. She does fit Natalie criteria, so would you give her adjuvant ribociclib?
It's a node positive, so
Yes.
with a higher risk. So I like to go with the CD4 inhibitor in add-on. R11,
So,
okay, but
so
it's
I'd
node
like to
positive.
clarify something. Oncotype tells you the benefit that you would get with chemotherapy. It does not tell you the benefit that you're going to get
So
with
the risk-
endocrine therapy or a
The
CDK4/6
risk stratification
inhibitor.
depends not only on the genomic profile, it also on the anatomical spread of the disease. So I
Okay.
like to have a node positive. So I like to have an
Okay.
endocrine therapy along with the
Okay.
CDK4 inhibitor.
Yes, you have your hand up.
I would give her endocrine therapy alone.
Okay.
Based on the.
Okay. So you're not a
P1
big
inhibitor.
believer of Natalie. Nitesh, what would you do?
Absolutely ribociclib. There's no question on this patient, in fact. So let me justify that. So Oncotype DX. Okay.
Doing that now.
So I'm going to show you some data later on.
And the other thing is, you know, we are talking about biology of disease. So when
Yes.
we're talking of biology, why do you want to escalate treatment?
Okay,
Let us
so-
keep it where we were. So, you
Okay, so the real question here is risk reduction in the long term. If you look, okay, so you will look at the curves, they are starting
To
together,
separate
then they're
after a
separate
couple of
afterwards.
years, yes.
And we already aware node positive disease is high risk in ER positive. Now, is it worth giving a chemotherapy?
No.
The answer is no. But is it worth reducing a risk of recurrence at year 3, 5, and 9? Answer is yes.
I would
And-
certainly have that conversation with her. It's not
again,
wrong
we
to
have
give
to-
and not wrong not to give. I think it's a conversation that you have with your with the patient.
So again, we
But
have
let's-
to
let's-
wait for more data because,
Yes.
you know, your overall survival data may not even come at 9 years. It may come at 10, 15, 20 years.
But we have level 1 evidence already, or 2A at least.
IDFS, we do have IDFS
So-
data.
So, and there's a study. There was a study done exactly for this group, and that was positive. How can I not
So,
give it to a
so let's go to the next question. We have a lot to cover. I know it's a very interesting debate. The next question is, do you believe with high risk node negative disease, patients should receive a CDK4/6 inhibitor? High risk node negative. Do you believe that based on Natalie?
Not yet.
No
I
data.
don't think.
All right, so hold that thought. I'm going to give you a case study. 40-year-old lady, premenopausal, she's got a PT3N0M0, and it's node negative. Her Ki67 is 70%, has grade 3 disease. She gets chemotherapy. Would you give her a CDK4/6 inhibitor? You would give her.
Definitely.
You just said that you don't believe in node negative high risk, that you would give
No,
CDK4/6.
as of date is not only based on the genomic profile alone.
Yes.
The
Yes.
choice of an endocrine therapy.
Okay.
It depends on not only on the genomic profile. In addition to that, still in the breast cancer, early breast cancers, the anatomical spread of the disease, the nodal involvement, the high risk features like the high grade disease,
Yes.
and Ki-67 starts to a certain extent now. Recently the Ki-67 have been taken out.
Okay.
But still, the anatomical spread of the disease still holds good in the EBC subset.
All right. So let me make it more difficult. You have a 28-year-old lady. She's got a PT1C, hormones receptor positive. Ki6. This lady was in my clinic yesterday, just in case you're wondering. Ki67, 90%. Her oncotype is 46. I consulted with 7 KOLs around the world. Everyone said, give her anthracyclines and taxanes. This is way too high risk for them to be comfortable omitting the anthracyclines. So AC Taxol. But now I'm going to give this patient AC-Taxol. Are you going to give her ribociclib in the adjuvant setting?
Yes. And I see what is happening is, the first case was a luminal A. Let's not forget that. This looks more like a luminal B.
Okay.
Young patient.
Okay.
You expect the disease to be aggressive. Here you have to attack her with the best.
Okay.
So I think in the whole conversation, we're talking about TNBCs, we're talking of HER2 positives, we're talking luminal A, but luminal B is the one which is actually pulling the carpet from under your feet. And this is one of those ones.
But this patient doesn't fit the criteria for Natalie because it's not a T2. It's a T1C. Nitesh, what would you do?
So the answer is yes, treat again.
Yeah.
So the whole exercise is risk reduction, and there's nothing else here. This patient incidentally will need a BRCA and maybe Olympiad.
It's all negative.
But the point here is risk reduction. And sitting in 2024, it's very difficult to deprive a patient of risk reduction exercise. So if you give her a CTK and she has toxicity, withdrawing it is acceptable, but not giving her an option is actually not acceptable.
I would have that discussion, but I would be very clear that strictly speaking, because it was an 18mm tumor, she doesn't fit Natalie, but I would really like to give her a CDK4/6. Next case, because we have a lot to cover. 50-year-old lady, she's postmenopausal, ER/PR positive, HER2 negative, 3-centimeter tumor, 2 lymph nodes that are positive, Ki-67 is 30%, grade 3. So she actually very nicely fits the Monarch E criteria, but her oncotype is 8. Would you give CDK4/6, and which CDK4/6 would you give? My medoncs on the panel, would you like to answer this question?
Abemaciclib.
You would give abemaciclib. Would you not consider ribociclib here?
So I would consider abemaciclib. In case of adverse events, only I'll change over to ribociclib.
All right. So just to give the surgeons an insight, we did see some molecular data from Monarch E at San Antonio this year. What they did was they looked at the benefit across different subtypes of hormone receptor positive disease. You can see luminal A is benefiting, luminal B is benefiting, but it's really that basal-like subtype that's not really benefiting that much from abemaciclib. Interestingly, they also did oncotype on all the patients. And you can see that the majority of the patients in orange had an oncotype of more than 25. You had a small subgroup with an oncotype of less than 25. It did not matter whether your oncotype was high or low. So long as you were high risk based on other criteria, you were still benefiting from adjuvant abemaciclib. And I think this is important. Oncotype is for chemotherapy benefit. It's not for endocrine therapy or CDK4/6 inhibitor benefit. So let's very quickly go to IO therapy in patients with triple-negative early-stage breast cancer. We saw the updated results of KEYNOTE-522, which gave neoadjuvant pembro followed by adjuvant pembro. In the 5-year updated analysis, there's still a good benefit. Absolute benefit is 9% in terms of event-free survival. For me, what was interesting, because I've seen KEYNOTE-522 so many times now, being presented at so many symposiums, is that before, in that PCR group, it didn't matter whether you got pembro or not, they all did the same. But now you're beginning to see a separation in the Kaplan-Meier curve, very slight, not statistically significant, but a nice trend showing that when you gave pembro, even in the setting of PCR, these patients were doing better. So, my question to you, in a patient who receives neoadjuvant pembro plus chemo and achieves a pathological complete response, is adjuvant pembro necessary? Medoncs.
Yes.
Yes? Nitesh, you have something to say? I still think maybe, maybe not. I don't think we've answered the question, but tell me.
I think it is maybe, maybe not actually. So giving immunotherapy in the group in the neoadjuvant setting is necessary or not? The answer is yes.
Yes.
But is there an advantage, and I do want Dr. Nangia's very important point of view here in a second, but is there an advantage of post-operative immunotherapy? We don't know. And I think that's a very relevant question for our country, because you're really talking 6-7 immunotherapies versus 17, and that's a completely different ballgame. So I think that's relevant. Dr. Nangia, what I wanted to ask you was, these numbers of immunotherapy in the neoadjuvant are going to escalate rapidly in the year and 2 years to come. And we know there is already discussion about radiation toxicity especially to the lung in these patients. So how do you address that?
I just don't want to forget that I also have another question about Pembro, but that's later. I have to say that finally the answers will come from radiation techniques, number one. Number two, I do believe that we are also looking at de-escalating. It's not happened yet, but already there is some work towards, for example, de-escalation, discussions about de-escalating treatment in HER2-positive patients who have a PAT CR. So how this is going to pan out eventually, only time will tell.
And I'll come to that. So let me go to the next case.
But may I just
sure,
ask,
sure,
what happens if a patient has not had neoadjuvant Pembro?
I'm coming to that. Coming to that. That's my next question. So, 38-year-old lady, she presents with a breast lump. She undergoes, for some reason, upfront surgery, 4 centimeter mass. Now, this is a real case. 4 centimeter mass, 6 lymph nodes that are positive, triple negative, Ki67 is 90%. PD-L1 was done on this patient, and it's 70%, and it was done at a very reputable lab. She then comes to see me. She is obviously for adjuvant chemotherapy. Would you add pembrolizumab in this patient?
Definitely.
Okay, next Medonk.
Now, for adjuvant pembrolizumab, I would not add as a...
Okay. Nitesh, what would you do?
Not yet.
So at San Antonio, we did see the results of the Impassion 030 trial that took patients with triple-negative breast cancer. It had upfront surgery, randomized to chemo-immuno versus chemo alone. No difference in the IDFS, but they used atezolizumab, not pembrolizumab. So I think at this point the jury is out. I think in 2024 we should not be using pembrolizumab in the adjuvant setting without having given it in the neoadjuvant setting. So next topic is using immunotherapy in the ER-positive, HER2-negative cohort, in fact beneficial or not. We saw 2 studies presented last year, the Keynote 756 and the Checkmate trial that looked at Nivo or Pembro in the neoadjuvant setting with chemotherapy. You can see the Checkmate 756 primary endpoint was PCR. When you added immunotherapy, PCR increased. There was a benefit of 8.5% in the Checkmate 7FL. There was a benefit in terms of PCR improvement by 10.5%. The biggest benefit was actually in those patients with PD-L1 positive disease. And you can see, but irrespective whether the PD-L1 was negative or positive, they were still benefiting in terms of improvement of PCR, in terms of getting a better PCR. So the question now is, remember, you can give Pembro if you want. It's free for you. What will you do in this case? Because this is a case that we'll be presenting to you in the clinic on Monday. 35-year-old, she presents to you with a 5 centimeter mass in her left breast, large palpable lymph nodes in her axilla. She ignored this tumor for quite some time. It's ER-PR strongly positive, HER2 it is negative, Ki67 25%. PET-CT reveals that there is uptake even in the supraclav lymph nodes. So this is a lady, young lady with T2 and 3 disease. She's obviously going to get neoadjuvant chemotherapy. Are you going to consider, I'm not talking the adjuvant setting, that's a controversial topic. I'm talking neoadjuvant. Are you going to consider adding pembrolizumab here?
Yes.
Okay. Anyone else? Pardon? PDL, we don't know. Nitesh, would you consider it? Would you have that conversation based on these 2 trials in this super high-risk patient?
Yeah, I certainly want Geeta and Dr. Mane's opinion on this also, because they're the surgeons in the house. I am reluctant, and I'm predominantly reluctant because this has been a philosophy change. For a long time we said immunotherapy does not work with ER. We're suddenly saying it does. So that philosophy change makes me reluctant, but the data is compelling, so it depends on the patient. But would you be comfortable, because we are not talking about toxicities yet, because that's another...
Yeah. I can tell you in my clinic, I would not start this. I've seen other people do it. I would not start it, because I think, one, we don't have event-free survival data yet, And I also think that we're already getting a good benefit with the use of adjuvant CDK4/6 inhibitor. She's 35. If she gets one bad toxicity, she's, you know, screwed, as I would say. But again, the data is there. So any comments?
We are not using it in neoadjuvant setting in ERPR positive case.
Okay. Okay.
So yeah, in a routine clinical, if all the supraclavian nodes were negative, and if it was a N1 disease, probably I would not use pembrolizumab.
Okay.
But she's at a very high risk, and I think there is evolving data that we can use pembrolizumab in neoadjuvant space in hormone positive as well.
Okay. So
in
then,
that case,
yes.
I would like to ask you, suppose you were to start neoadjuvant pembro and then she was to have kind of partial response. So what do you do now? Are you going to do a pembro? Are you going to, where are you going to bring the CDK4/6 into?
Oh, I 100% in the adjuvant setting, I would not offer this patient pembrolizumab. This patient would get 100% adjuvant CDK4/6. The data is very clear for that. But in such a high-risk patient that this conversation is repeatedly going to come up, to increase the PCR rate, which has never been an endpoint for us for ER-positive disease, but appears to be now, we now have 2 trials that are telling us you add immuno, this might work. So let's go to the next question, because Nitesh has given me some leeway, but not too much. How do we optimally manage patients with ER-low disease? We saw data at ESMO last year telling us that patients who have ER-low disease actually behave very similarly to patients that have triple-negative breast cancer. We also saw from the Keynote 756 trial, which was the immunotherapy trial, that the biggest benefit actually are in those patients who have an ER positivity of less than 10%. I mean, that hazard ratio is very, very good. When you look at Monarch E, you can see that adjuvant CDK4/6, this was again presented at ESMO, was beneficial irrespective of the level of ER positivity. So now you're in a conundrum. How are you going to treat patients with ER-low disease? And we know that abemaciclib benefited patients irrespective of their PR status as well. So I have a 45-year-old lady. She has a clinical T4N1 disease, no metastatic disease. ER is 9%, PR is 5%, Ki67 is 50%. She will get neoadjuvant chemotherapy. Are you going to give her neoadjuvant pembrolizumab? Hard question? Anyone from the audience want to chip in? I'd love for you to chip in. Tell me.
She's 45-year-old. And you want to ask about neoadjuvant, right?
She's getting neoadjuvant treatment. It's a clinical T4N1. So are you going to
I would not be adding pembro right now.
You will not add pembro. Okay. Anyone else?
So, you know, like you said, you know, she seems like a triple negative because of such a low ER positivity and a high-grade disease. And clinically also she's a stage 3B.
Yes,
I would think it may be worthwhile thinking about a pembrolizumab.
So I have to admit, I did offer her adjuvant pembrolizumab. If you give adjuvant, and now this is for Nitesh, if you give neoadjuvant pembrolizumab, are you going to give adjuvant CDK4/6? How are you going to approach this lady? These are patients that come to you in the clinic.
So the answer is yes to both. I think there is some data on based of which I agree looking like triple negative, and so I would give neoadjuvant immunotherapy.
Okay.
But she's again clearly a case for CDK inhibitor with abemaciclib
In the adjuvant setting.
These are the patients who always
Exactly.
worried us.
This
that
is what I
Dr.
would do,
Harrit
but-
would be worried about these for 2-3 decades and wondering where the answers will come, and these are where the answers are coming from.
Yes.
CDK4/6 inhibitors work for low ER positive patients also.
Yes,
in
because-
metastatic disease, it has been documented for palbo also.
So in Monarch E, anyone who had an ER more than 1% as per the CAP guideline.
I will be using CDK4/6 inhibitor.
So for this patient, definitely CDK4 inhibitor.
Yeah.
Discussion with pembrolizumab is offered.
Okay. So I have 2 more questions that I'm going to ask, and then, do I have 5 minutes? 2 more? Yeah? Okay, so the next question is actually adjuvant TDM1 in patients with HER2 positive disease. We saw the overall survival data for the Catherine trial at San Antonio. Finally, we know that there is a 4.7% overall survival benefit at 7 years. But when you look at that subgroup of patients with minimal residual disease, it's actually not statistically significant. So, in a patient that has a YPT1A residual disease, are you going to offer them adjuvant TDM1?
This was a very interesting question that we had, so it was just 1 millimeter. So the medical oncologist obviously got to the people who made the model, who did the trials and all of that. And they say, as of now, any residual would warrant a
even
TDM1.
Isolated tumor cells in the breast, Nitesh?
So 1 mm.
So yeah, so 1 mm, but this, we were waiting for this data to come out, and I think we all predicted it will be negative, and it is negative. So actually, this is now we can stop escalating.
Okay, last question, and I promised the Radong that I'd be asking this question. Can we safely de-escalate radiation therapy? And I'm being very opportunistic because I have a patient in the clinic that this discussion is currently going on. We saw the results of the NSABP B51 study that was presented at San Antonio that took patients with a clinical T1 to T3 N1 disease, irrespective of biology. They all got neoadjuvant chemotherapy if they attained a pathological complete response and they had a mastectomy. They didn't get radiation, or they did. This was a randomized trial. And patients who had breast-conserving surgery would only get radiation therapy to the chest wall and not the axilla. And you can see there was no difference between those who got radiation versus those who didn't. So my last, and the subgroup analysis also showed that if you had HER2-positive disease, it didn't really matter whether you gave radiation or not. But I was actually a bit concerned when I saw the patients with the triple-negative breast cancer, because you can see the point estimate is actually going in the wrong direction. So my last question, and I promise, you have a 45-year-old lady, high-risk disease, HER2-positive, given neoadjuvant chemotherapy. She receives dual blockade. She attains a pathological complete response. She has a mastectomy. Are you going to omit radiation therapy in the adjuvant setting?
Only omit radiation therapy in the axilla.
But not, but she's had a mastectomy. The trial said even
at present not.
Okay, okay.
I think we are going to get there at some point of time, but I don't think we understand enough.
Okay. This is my last one, by the way.
Axilla, anyway, you are not giving radiation.
No, in fact, one of the questions of B51...
No, residual disease, nothing is there.
No, actually, in B51, the question that was being asked was, in the axilla, will you treat the undissected axilla with radiation or not treat the undissected axilla with radiation? So the the axilla, for example, if only level 1 has been done, will you treat level 2 and 3? And so the answer was that no, adding an additional axillary treatment made no difference. So yes, we have stopped treating the axilla, but at present I don't think we are...
So during the discussion section in San Antonio, there was actually a debate about this, and the consensus, at least for this data, was that you could offer the patient to omit radiation therapy in those who had had a mastectomy, but of course it's clinical T1 to T3, N1. But this is HER2 positive. I'm actually quite comfortable to discuss with my patient with the radon, because I'm not a radiation oncologist, because we not only have this data, we've got a lot of other data suggesting that in HER2 positive PCR, you could potentially omit.
So as I mentioned earlier...
But what about, because my time is up, I'm sorry, what about if this patient was triple negative and had attained a PCR? Would you omit either axillary radiation or chest wall radiation?
So in triple negative, I don't think we are there yet. In HER2, yes, as I mentioned earlier, we are definitely getting to a point where we might be able to de-escalate. However, not for triple negative. No, actually the question was only undissected axilla. I think as radiation oncologists, we are moving more and more towards regional nodal irradiation, not necessarily the axilla, but definitely, for example, for a medial quadrant tumor, the internal mammary and supraclav irradiation has now been shown to have survival benefit. So no, not omission of nodal irradiation entirely.
Well, thank you very much. Our time is up. I must thank Shaina. She always makes it interesting. For Breast Oncology Room, this is the most interesting discussion we've had. Thank you very much, and over.
That was an exemplary panel discussion. I thank Dr. Shaina Dawood and all the panelists and the chairperson for that. Next, I invite for the session on contemporary approaches to classifying cancer by histologic type and staging beyond current publication. I invite chairpersons Dr. Bhauman Dhabar, Director Medical Oncology, Fortis, Mumbai, Dr. M. Vijay Kumar, Vice Chancellor, Surgical Oncologist, Enapoya Universities, Mangalore, Dr. J.P. Agarwal, Head Department of Radiation Oncology, Tata Memorial Hospital, Mumbai, Dr. Mohan Keshav Murthy, Senior Director, Urology, Fortis Hospital, Bangalore. For this, I invite our esteemed speaker, Dr. Mahul B. Amin, who is Clinical Professor of Pathology and Laboratory Medicine, University of Tennessee Health Science Center, Professor of Urology, University of Southern California, Keck School of Medicine. I invite you, sir. Thank you.
Can we check the lapel mic, please? Good morning, ladies and gentlemen. It's a real honor and delight to be here. I'm extremely excited to give this talk. I see very familiar faces in the audience, 30 years of interactions with Indian oncologists and urologists and surgeons. So what I'd like to do today, with the kind invitation from Dr. Sharma, who has coordinated this part of the presentation, is to give you a glimpse of how, as organizations in the WHO and the AJCC, we approach classifications of human tumors. And we all accept the central dogma of cancer management, and that really, cancer is managed as a team medicine or team science. It is the surgeons, as we saw very well here, with the radiation oncologists, with the pathologists, imaging people, all our nursing staff, behavioral team medicine, to really bring together the best outcome. But the central aspect of any cancer management is to start with an accurate diagnosis, because it is really the most essential aspect of disease management in cancer. And so why is this the central dogma? Why do we need to classify cancer? Well, it is really in this team medicine to talk to each other, to talk to patients. It is a uniform nomenclature used by all physicians, scientists, public health, policymakers, registrars, surveillance community, to understand, manage, and record and study disease. And through this very systematic communication of the language of cancer, we establish appropriate management paradigms with the aim to improve cancer care, foster meaningful research, and most importantly, at the end of this, there is a health policy formulation that is an important outcome of cancer management, because cancer is obviously evolutionary in its management as we understand it. So how do we classify cancer? And it's not just one approach, one system, but really we take into account the histologic type. Of course, that's the basis, the foundation on which cancer is classified. But it is also the extent of disease, the TNM system. And in this modern era, since the turn of the century, really very important is to understand the molecular profile of classification of cancer. So let's begin this journey and get it to 2024. But really, where is this field going beyond as we look at it from these organizations that look at classification? Our understanding of the histology began right in the 1700s when, of course, Anton Leeuwenhoek made the discovery of the light microscope. And this light microscope helped us understand what the pathology was. And pathologists, and I know there are several in the audience, put together the gross, the microscopy, the clinical information, they do additional tests, and together with this information, they arrive at the pathologic diagnosis, which is obviously the foundation of disease. In the 1980s, a pathology report looked something like this. You know, it would be very descriptive. infiltrating cancer, grade 3, this is the size, how many lymph nodes involved, and what was going on with the background breast. But one of the issues with histopathology, at least perceived by many of the clinicians, was there is a level of subjectivity. If one looks at this picture, is this a skull or is this a lady getting out to go out for dinner in the evening? The subjectivity aspect of pathology was well understood. And so the role of pathology was challenged because what pathologists were doing, and appropriately so at that time with the level of information, was to give the primary diagnosis and to give some prognostic information appropriate for management. At the turn of the century, as I said, we really got an intense focus on understanding the molecular basis of disease. And this molecular basis of disease has allowed us to take this on to discussions like we are having today with the theme of precision oncology. To the extent that there are some clinicians who feel, why classify histologically? It's all in the molecular. And so before we put the microscope at rest, which is not, it is the foundation of disease, it's really important to understand the very important contributions of microscopy. The classification of all neoplasms into carcinoma, sarcoma, blastomas, gliomas, lymphomas comes from the light microscope and understanding the histology, which is the basis. The entire concept of grading and staging of cancer has a lot of basis in microscopy. We've been able to identify very specific infectious diseases, and more importantly for cancer, diseases that are not related to an anatomic site, but based on biology or of cell of origin, gonadoblastoma, picomas. We see it in all organs, desmoplastic round cell tumor. These are examples of what the light microscope has done, and it will continue to do so. As we continue this journey at the turn of the century, the aim was to understand single genes that were important, classify that, and add it to the management and help not only prognosticate, but also help predict. That means to help the management of selection of therapy, and of course the well-known example of HER2 in breast cancer is known. And the reporting of prostate cancer, of breast cancer became therefore a little more systematic, and there were efforts in the United States and now all over the world to give information in a very consistent and synoptic fashion so that physicians from all across the world, whenever they're seeing it, they will see the consistent information that is reported for cancer. And so not only were we reporting the type and grade and stage, but also we start seeing prognostic and predictive factors as illustrated here, including the TNM stage, ER, PR, HER2, MIB1 status. What really changed the game for cancer is this paper and this huge, humongous effort by scientists to understand the human cancer genome. And that project, as you know, was completed in 2001. The studies were published in 2001 in Nature. And in addition to this pioneering work, which was just an 8-year project costing over $1 billion, there were other win studies. For example, you saw this case. There was this paper that was published in the New England Journal of Medicine about a lung cancer patient who had activating mutations of EGFR and response to gefitinib therapy, and so the story of personalized medicine and that promise started to catch on. So really, at a very high level, where is precision medicine? What is it doing, and what's really its scope? Well, as we all know, precision medicine, precision oncology fosters a new paradigm of looking at cancer through high-throughput multiomics. And this, when combined with the health information record, gives us an incredibly powerful tool to look at cancer. And at the end of the day, our human body has about 30 to 40 trillion cells. And these cells, each of them have 46 chromosomes. Each of these, the entire chromosome, if you look at the chromosome profile, the fingerprint for cancer is about 3 billion base pairs. So everything that we are trying to understand is this: what's in those 3 billion base pairs? What is in those 25 genes that are encoded in these base pairs, and about the 500,000 proteins that are expressed through this very fascinating human genome. Along the way, after the human genome came the project for TCGA, where there was a very comprehensive profiling of about 11,000 patients, 33 cancer types, including rare cancers. And again, funded by the National Cancer Institute, was a very comprehensive look at the copper number alterations, the omics in terms of methylation, gene expression profiling, microRNA analysis. So really, every which way, cancers were comprehensively looked at. And this was not really to understand diagnosis, but to understand what is the molecular pinning, which are the mutational drivers, which are the passenger mutations, what are events that are occurring post-transcriptionally, methylation, et cetera, et cetera. And this gave us a very good glimpse and the start of an accelerated process to discover new diagnostic and prognostic tools. The BRAF V600E mutation and its therapeutic target came from this effort. And of course, we understood multiple new types of cancers, such as the ELOC mutated kidney cancer, IDH mutant gliomas, and the work goes on. And of course, it's not the NIH only doing the work, it's the work that is done collectively by all academic institutions around the world that took this information that's publicly available, and people are building on this. And of course, one of the success stories of those TCGA is the whole story of the V600E mutation. And here a patient who showed excellent response, but as we know in cancers, they evolve genetically, and obviously the issue of relapse and remission. So let's take an example of what happened to breast cancer. We had a very fascinating, a little provocative, but really important discussion on breast cancer. And the histologic classification of breast cancer here by the WHO has now evolved, and I heard the discussions of luminal type A and B, and the purpose here is not to go into the details, but how this molecular characterization has impacted our understanding of human cancer classification. Now, key is, well, these discoveries are fine and dandy. What about its translation at the point of care for our patients? And this transition into genomic medicine at the bedside has really been enabled by genomic and high-throughput technologies that we can take into clinical areas and get results in an actionable fashion, so that you could get a result in a week or 10 days and work on it. And understanding that in the end, these molecular pathways are important for survival and prognosis, and that there are anti-cancer therapies that are available for these oncogenic pathways, and so they are entered into clinical trials and then into clinical medicine, and these were very elegantly discussed in the previous section. This is an old paper by Vogelstein, but really set the tone for what is happening here, that at the end of the day, there are driver mutations, there are 12 signaling pathways, and as you understand these pathways and where the genes are expressed, and these pathways fall into cell fate, cell survival, and genome maintenance, you can really classify cancer and identify those molecular targets that are actionable or treatable. And so the whole concept, and I'm sure we're going to discuss more of this in this conference, is the evolution of the molecular profiling to histologic classification. Small cell carcinoma, non-small cell carcinoma, that's when we studied classification of lung cancer when we were in medical school. And of course, this has now evolved. We know that it is not only non-small cell carcinoma, but the adenos and squamous. Each has a very, very unique molecular profile. And even though the two carcinomas can look under the microscope, here is a recent publication of the oncogenic mutations in non-small cell lung cancer. You can see EGFR mutation being one of the most common there, KRAS, ROS, BRAF, the usual culprits involved in the progression of, in the genesis and progression of lung cancer. And similarly, signatures of diseases that were thought homogeneously and approached homogeneously in terms of management have these unique molecular profiles, and these pie charts, these are a couple of years old, but they constantly continue to evolve. Now the discoveries is in a narrow zone, but we are still making very important observations. Most importantly, the whole concept that histologically and clinically similar cancers are very unique at the individual patient level, and that, of course, is the premise of precision oncology. Now, what this did is it took two cancers that looked the same under the microscope, lung cancers, if it had an EGFR mutation versus ALK rearrangement, cancers looking the same with different treatment paradigms. But you also had different cancers that had no relation to one another. You take CML and you take GI stromal tumors, and they're treated similarly because of the underlying molecular pathways. And so the whole concept of diagnosis, agnostic therapy has come in. It really doesn't matter what is the diagnosis, is what is the molecular profile that is indicating a potential way to treat the cancer. Now, not only has it been exciting to have this wild ride with mutational analyses and targeted drugs, but we see the whole field of immuno-oncology, and this was also well discussed, where you see, and this is a field that's less than 2 decades old. You know, in 2018, Allison and Honjo won the Nobel Prize for this work. We know cancers are immunogenic. We know that cancers learn to evade the immune system. And we can train the immune system to fight the cancer. And of course, that is the basis of the entire immuno-oncology work. And so if one looks at the burgeoning, ever-expanding list of genes and targetable, druggable mutations and fusions, here's just a list of all these different drugs and approaches we have in our therapeutic armamentarium: tyrosine kinase inhibitors, therapeutic antibodies, ALK, PARP inhibitors, etc. And the list just continues to expand. Also, from the United States and a regulatory perspective, making sure that is the work in the interest of patients. FDA has approved over 8 immunotherapy drugs for 37 different cancer types, just again in the last 10 years or 15 years since these drugs have been available to us. And so as one looks just in 10 or 15 years, immunotherapy has an impact over different 60 cancer types. So where is this So we talked about histologic classification. Where is over 8 immunotherapy drugs for 37 different cancer types, just again in the last 10 years or 15 years since these drugs have been available to us. And so as one looks just in 10 or 15 years, immunotherapy has an impact over different 60 cancer types. So where is this So we talked about histologic classification. Where is over 8 immunotherapy drugs for 37 different cancer types, just again in the last 10 years or 15 years since these drugs have been available to us. And so as one looks just in 10 or 15 years, immunotherapy has an impact over different 60 cancer types. So where is this So we talked about histologic classification. Where is over 8 immunotherapy drugs for 37 different cancer types, just again in the last 10 years or 15 years since these drugs have been available to us. And so as one looks just in 10 or 15 years, immunotherapy has an impact over different 60 cancer types. So where is this So we talked about histologic classification. Where is over 8 immunotherapy drugs for 37 different cancer types, just again in the last 10 years or 15 years since these drugs have been available to us. And so as one looks just in 10 or 15 years, immunotherapy has an impact over different 60 cancer types. So where is this So we talked about histologic classification. Where is over 8 immunotherapy drugs for 37 different cancer types, just again in the last 10 years or 15 years since these drugs have been available to us. And so as one looks just in 10 or 15 years, immunotherapy has an impact over different 60 cancer types. impact how cancer will be classified in terms of molecular and computational classification. And from that perspective, we are really at the point where the microscope was discovered. If someone thinks precision oncology is here, no, we have just started to understand precision oncology. And what is going to happen is that we're going to have to fasten our seatbelt, because the human knowledge, every century till the last century doubled, every century you double the knowledge. In medicine, now we are doubling knowledge every 7 to 8 years. In precision oncology, we are doubling knowledge in 2 to 4 years. So it is just the start of a very fascinating journey. And I'm sure there's more to come. So thank you for your attention. And
thank you. That was absolutely stupendous as usual, Dr. Amin. Thank you very much. A quick question from me, and then we'll have one question from the audience. We are running very short of time. Why don't you ask, please?
Yes, Dr.
A brilliant talk, Dr. Mahul, as usual. Considering your global leadership in your own path, I have two very specific questions. Where do you see virtual biopsy using confocal microscopy, especially in renal cancers, intraoperatively, replace traditional frozen section biopsy? That's question number one. Question number two, in the last year, both in the US and in certain parts of India, we are looking at no biopsy treatment of cancer prostate using multiparametric MRI and PSMA PET. Where do you see that going?
So, very fascinating question. I think in order to understand biopsy approaches, or not to do a biopsy, or to limited biopsies, we are in the era of collecting data. So we are looking at multiparametric MRI, blinded to that in AI studies, because this is big data. The human mind and all of us investigators together will not be able to figure this out. Multiparametric MRI with biopsies that are just provided with genomic and H&E data, with PSA data, with PSMA, is allowing us to look at algorithms that will help us better define which patients. So the aim is biopsy avoidance when we should avoid, so that you don't have unnecessary cancer, because that's led to the whole debate, is Gleason 6 even cancer? So we want to detect cancers that are clinically significant, and all of this is going to require these information. So I think just to keep it at the general level of where we are for a pan-oncology audience, it is what I said. It's the next 10 to 20 years that when we put together and we build this team science, and the imaging and the clinicians and the oncologists and radiation oncologists are working together to put big databases together, and then understanding. And I cannot, we've gone to New Delhi and have conversations at the Prime Minister level and many others at the National Cancer Institute in India, I forget the name of it right now, that we need India-specific genomic data, because we are acting too much on data that is there. So more discussions, but for this level, I think hopefully that helps you understand. It's going to be, if people think precision oncology is here, no, precision oncology is born, and precision oncology has to evolve, and we are all going to be part of that exciting journey.
Thank you.
Nitesh, you had a question, or you want to take it offline?
No, I have a question actually. I mean, you're right. This is disruptive question. If you had to redesign pathology, would you still do organ-based classification, breast cancer versus prostate, or you in fact hinted that in your slide, or you would actually start off with maybe immunohistochemistry and go on to molecular, and then, because from therapy perspective, it actually makes sense that we are agnostic to where the tumor started from.
So
So this is very